There are different forms of skin disorders that you will have to know for your Step 1 exam. So I have divided these skin disorders into 2 videos. In a separate video, I have discussed the skin cancers, which included the squamous cell carcinoma, basal cell carcinoma, as well as melanoma. And now here, I'm going to focus the other forms of the skin disorders. Now, in order to understand these disorders, first I would like to discuss the normal structure of the skin. So the skin is made of 3 layers. The epidermis, which is the outermost layer and is made of a stratified squamous epithelium. Then we have the dermis, which contains the blood vessels, as well as lymph and nerves. And then underneath dermis, we have the hypodermis, which contains the subcutaneous adipose tissue. And so the epidermis itself is divided into 5 layers, which you will have to be familiar with. And these layers include, from the top to the bottom, stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, as well as stratum basal. And so the memory aid that I have for you is that Californians like girls in short bikinis. So Californians like girls in short bikinis. And so this way you can now remember the order of these epidermal layers. Now, from the bottom, we have the stratum basal, and this layer contains the stem cells that give rise to the keratinocytes. And so if there is a malignant transformation of the basal layer, it would give rise to basal cell carcinoma. The next layer is stratum spinosum, which is very rich in desmosomes, and it's also the site where melanin is being transferred from the melanocytes to the keratinocytes. So melanin is being transferred from melanocytes to the keratinocytes. The next layer is stratum granulosum, and this layer, the name granulosum is given to it because the keratinocytes are becoming granular, where they would become flattened and slowly die to form the final layer, which is the stratum corneum. And so here we have granular cells. And then the stratum lucidum is a layer that is specific to the palms and soles, and this layer is made of specialized cells that make a clear layer. And then finally, the outermost layer is stratum corneum, which is made of dead cells that have lost their nuclei. So these are anucleated dead cells that form the outermost layer and function as a protective layer. And then in addition, these cells contain a dense network of keratin. Now there are 4 types of cells that exist in the epidermis, and these cells include stem cells, which are in the stratum basal, and these cells give rise to keratinocytes, and then keratinocytes themselves produce keratin, which will build up in stratum corneum and form a protective layer. And then melanocytes, which are derived from the neural crest cells, are producing melanin. And the mechanism through which melanin is being produced is that tyrosine, via the tyrosinase enzyme, is converted into DOPA, and then DOPA is converted into melanin. So once again, melanocytes are derived from neural crest cells, and these cells produce melanin from the tyrosine. The other form of cells that we have are Langerhans cells, which are the antigen presenting cells. And then finally, we have the Merkel cells, which are associated with the nerve fibers to help for the position sensation. Alright, with that information in mind, now we can proceed and discuss different forms of skin disorders. So the first disorders are the pigmented skin disorders, which includes the albinism, and albinism is due to the lack of the melanin production, which could be either from the deficiency of the tyrosinase or tyrosine transporter proteins, or it could be from the failure of neural crest cells to migrate. So you may recall that I told you that melanocytes are derived from neural crest cells, and then the melanin is being produced from tyrosine. So if there is deficiency of the tyrosinase or tyrosine transporter, and then there is problem with the neural crest cells which give rise to melanocytes, Therefore, there won't be any melanin production. So either the deficiency of tyrosinase or tyrosine transporters or failure of the neural crest cell migrations will cause lack of the melanin production. And then the image above shows you examples of albinism which can exist in different species. The next condition is vitiligo, and this condition is due to the autoimmune destruction of the melanocytes. And so in fact, since this autoimmune disorder is also associated with other forms of autoimmune disorders, particularly the thyroid disorders, therefore it's recommended to test the thyroid function test in patients that have vitiligo. As for the treatment of vitiligo, you can treat these patients with topical or oral corticosteroids. And then you can also consider UV light therapy as well as skin grafting techniques. Freckles result from increased number of melanosomes, which are the organelles that are required for the production of melanin. And so here you can see that there are these hyperpigmentations that are referred to as freckles. The next condition is melasma, where there is hyperpigmentation of the skin that is typically seen in the sun-exposed areas of the face, and risk factors to the development of melasma include darker skin as well as pregnancy and oral contraceptive use, and that is very important. So the fact that elevated progesterone and estrogen are associated with the development of melasma, it's thought that these hormones will induce the production of melanin, as a consequence of which it would cause hyperpigmentation. And then for the treatment of melasma, you could consider providing sunscreen with the sun protection factor of more than 30, and then you can also try different topical creams. The next forms of skin disorders are proliferative disorders. And so the first condition is psoriasis, where there is a thick stratum corneum with nucleated cells. So you can recall that the stratum corneum was made of dead cells with no nucleus. So in patients that have psoriasis, the stratum corneum layer has retained nuclei within cells. And so the other term for it is parakeratosis, meaning that there is retention of nuclei in stratum corneum. Now, in terms of the clinical presentations, patients with psoriasis present with silvery scales on the knees and elbows. And so the memory aid that I have for you is that psoriasis presents with silvery scales. Now, other histological findings that you may see with psoriasis includes thick stratum lucidum, and you may recall that stratum lucidum was a specialized layer that was found in the soles and palms, and then there is a thin or absent granular layer. So the granular layer was the layer that was preparing to flatten cells and lose nucleus. So the fact that there is thin or absent granular layer explains why the nuclei has been retained in the stratum corneum. And then this type of skin disease is also associated with psoriatic arthritis. And so it has been shown that as many as 48% of patients with psoriasis can also have psoriatic arthritis. And then if you try to manually remove these skin lesions, what will happen is that after you remove these lesions, there would be pinpoint bleeding. And so this finding, where upon removal of the scales there would be pinpoint bleeding, is referred to as Auspitz sign. And then for the treatment of patients with psoriasis, there are multiple medications that you can use. You can use topical corticosteroids, retinoids or vitamin D, phototherapy, methotrexate, cyclosporin, etanercept, as well as infliximab. But then patients that have also psoriatic arthritis, you should consider treating these patients with NSAID as well as the disease-modifying anti-rheumatic drugs like, for instance, methotrexate. The next condition is seborrheic keratosis, where there is a benign proliferation of immature keratinocytes. And then on examination, you will see a round lesion with verrucous surface and a Stock-on appearance. That is shown here in this image. And then the histological findings include cysts that contain keratin, an example of which is shown right here. Now you should know that seborrheic keratosis, these lesions are usually benign and slow growing, but then if there is a sudden appearance of multiple seborrheic keratosis, then there is a possibility that there is a form of malignancy that is present in that patient. And this is referred to as lesser Trellat sign. Now, as for the treatment, again, since these lesions are benign and slow growing, only if there is a cosmetic concern you could consider treating these patients. And so for the treatment, you can use cryotherapy or shave excision. The next disorders are blistering disorders, and so in order to understand those, first I would like to discuss the structure of the skin that will hold cells together. So here I have two cells in the epidermis that are being held together. So we have the tight junctions, the other name for which is zona occludens. And these tight junctions, which are composed of claudines as well as occludins, will prevent paracellular movement of the solutes. The next junction is the adherens junction, the other name for which is zona adherens. And these junctions are made of the E-cadherin as well as actin filaments. And so their function is to join actin bundles in two adjacent cells. Next we have desmosomes, the other name for which is macula adherens. And the function of desmosomes is to join intermediate filaments in two adjacent cells. Next we have the gap junctions, which are made of connexons that will allow direct communication between the two cells. And then finally we have the hemidesmosomes, which function to join the intermediate filaments to the basement membrane. So once again, the intermediate filaments are being joined to the basement membrane by hemidesmosomes. Now the first disorder that I would like to discuss is bullous pemphigoid, which is due to the formation of autoantibodies against hemidesmosomes. So first we have bullous pemphigoid, where there is formation of autoantibodies against hemidesmosomes. And so therefore, on immunofluorescence staining, you will see linear IgG and C3 staining that is along the basement membrane. So since the antibodies are attacking the hemidesmosomes along the basement membrane, the form of immunofluorescence staining that you get is linear. And so these patients generally present with cutaneous lesions, an example of which is shown here. But then there is no mucosal lesions seen with bullous pemphigoid. And then you could consider either topical or systemic corticosteroids for the treatment of bullous pemphigoid. The next condition is Pemphigus vulgaris, which is due to the formation of antibodies against the desmosomes. And so the features of Pemphigus vulgaris is that IgG antibodies are formed against the desmosomes, as a consequence of which, when you obtain an immunofluorescence stain, since we are staining now for the desmosomes, it will have a fishnet or lace-like appearance. And then unlike the bullous pemphigoid, which only had cutaneous lesions, Pemphigus vulgaris has both mucosal and cutaneous involvement. And so therefore, due to the mucosal involvement, patients with Pemphigus vulgaris can have severe oral pain that will cause them not to eat food, as a consequence of which it can cause also malnutrition and weight loss. Now, one other difference between bullous pemphigoid and Pemphigus vulgaris is that with Pemphigus vulgaris, it's a more superficial skin disorder since the desmosomes are being affected. And so therefore, if you apply manual pressure to these lesions, the skin would come off. And this is referred to as positive Nikolsky sign. Versus bullous pemphigoid, which is a deeper skin lesion since now the hemidesmosomes are affected. And so therefore, these lesions have a negative Nikolsky sign because the skin wouldn't come off by applying manual pressure to the lesions. Now here is to summarize the difference between bullous pemphigoid and Pemphigus vulgaris. So bullous pemphigoid is due to the formation of IgG antibodies against hemidesmosomes, and so therefore you will see linear immunofluorescence along the basement membrane. This form of disorder is only having cutaneous involvement and does not affect the mucosa, and then there is a negative Nikolsky sign. And so the memory aid that I have for you is that bullous pemphigoid affect the layer below the epidermis. So you know how the antibodies are being formed against the hemidesmosomes, which are at the lower level of the epidermis. So that's how you can memorize that bullous pemphigoid is affecting the layer below the epidermis. And then with the Pemphigus vulgaris, the way I memorize it is that the disorder is so vulgar that causes mucosal lesions, in addition a positive Nikolsky sign where manual pressures can cause blistering induction in these patients. And then other features is formation of IgG antibodies against desmosomes, as well as the fishnet or lace-like appearance on immunofluorescence stain. The next disorder is Erythema Multiforme, where there would be target-like lesions on the skin. So here you can see that there are target-like lesions that are being formed on the skin, and here is one obvious example. And so 90% of the cases of Erythema Multiforme are from infections. And then there could be other causes, like for instance medications from sulfa or beta-lactams, malignancy, or autoimmune disorders that can also cause Erythema Multiforme. But then again, 90% of these lesions are from infections. And then among infectious causes, herpes simplex virus is the #1 cause of Erythema Multiforme. And then after that, Mycoplasma is another common cause. Now it's thought that cell-mediated immune process, which is directed against the viral antigen, will deposit in the skin, and so therefore it will cause formation of Erythema Multiforme. The next skin disorder is Stevens-Johnson syndrome, which is a severe mucocutaneous reaction that is triggered by medications, example of which include, for instance, sulfonamides, phenobarbital, as well as carbamazepine. This type of skin lesion is characterized by extensive necrosis and detachment of the epidermis, but then it only affects less than 10% of the body surface. And then the more severe form is called toxic epidermal necrolysis, which affects more than 30% of the body surface. And once again, there is detachment of the epidermis in these patients. So you can see how the epidermis has come off in patients that have toxic epidermal necrolysis. And similar example you would see with the Stevens-Johnson syndrome. So the difference between toxic epidermal necrolysis and Stevens-Johnson is that with Stevens-Johnson, less than 10% of the body surface is affected, while with toxic epidermal necrolysis, more than 30% are affected. And these conditions are actually very fatal, and you should consider admitting these patients to the hospital for supportive treatment, as well as infection control and sterile handling. And then the mortality rate in toxic epidermal necrolysis is as high as 40%, while in Stevens-Johnson syndrome it's as high as 10%. Next, we have the infectious disorders. So the first one is Staphylococcus scalded skin syndrome, which is common in neonates. And so exotoxin-mediated destruction of keratinocyte attachments in stratum granulosum will cause this form of skin peeling that is shown in this image. The next condition is impetigo and cellulitis, which are caused by group A streptococcus as well as Staphylococcus aureus. And so with the impetigo, one important feature is that there would be honey-colored crusted lesions. And so for the treatment of these patients, you should consider antibiotic treatments that are directed at Staphylococcus aureus as well as group A streptococcus. And so these antibiotics include the diculoxacillin as well as cephalexin. And then cellulitis is another condition that you will most likely encounter during your medical school rotations as well as during your residency. And so these lesions are usually caused due to breaches in the skin barrier and present with the skin erythema, edema, and warmth due to the involvement of dermis as well as the subcutaneous fat. And so for the treatment, you should direct antibiotic against the methicillin-resistant Staphylococcus aureus, for which you can provide clindamycin, trimethoprim sulfamethoxide, as well as linezolid. So just note, all these are the medications that are used against methicillin-resistant Staphylococcus aureus. And so here is an image of the cellulitis, where you can see that there is skin erythema that is affecting the leg, and here is an example of impetigo with the honey-crusted lesions. The next form of infection is necrotizing fasciitis, which is caused due to the formation of subcutaneous crepitus from infection by either anaerobic bacteria or Streptococcus pyogenes. And this is due to the formation of CO2 or methane under the skin, as a consequence of which it will cause progressive destruction of fascia and fat. As for the treatment of necrotizing fasciitis, you should consider surgical exploration and debridement, in addition to antibiotics, as well as hemodynamic support. The next form of skin disorders are Lichen Simplex, Lichen Sclerosus, and Lichen Planus. So Lichen Simplex is from chronic irritation and itching, after which the patient keep on scratching the skin that causes a thick, leathery skin from hyperkeratosis. So there is actually squamous cell hyperplasia. The next condition is lichen sclerosus, which is presenting as white vulvar lesions that are seen in postmenopausal females. So that's very important, that postmenopausal females, if they present with white vulvar lesions, you should start thinking of lichen sclerosus. And then there is a slightly increased risk of squamous cell carcinoma with lichen sclerosus. And then in terms of the histological presentations, there would be atrophic epidermis with sclerosis of the dermis. As for the clinical manifestations, patients with lichen sclerosus present with vulvar pruritus, dysuria, dyspareunia, which means that there is painful intercourse, as well as fusions over clitoris as well as labial tissues. And so for the treatment of these patients, you should consider topical or intralesional corticosteroids. The next condition is Lichen Planus, which presents with the pruritic, purple, planar, polygonal papules that are associated with hepatitis C. So the way you can memorize it is that Lichen Planus is associated with 5 P's. Pruritic, purple, planar, polygonal papules, the incidence of which increases with hepatitis C infection. And then there is a very rare risk of progression into squamous cell carcinoma. And then on histology, you will see sawtooth lymphocyte infiltration at the dermal-epidermal junction. And so these are examples of the forms of lichen simplex that I told you about. So there is hyperkeratosis from excess scratching. And then here we have a lichen sclerosus, where there are white vulvar lesions that are seen in postmenopausal females. So that's very important. And then finally, we have lichen planus, which presents with 5 P's, which stands for pruritic, purple, planar, polygonal papules, an example of which are shown here. The next condition is Pityriasis Rosea, which is a self-limited inflammatory condition that is seen on the trunk and proximal areas of the extremities. And so these lesions usually start presenting as herald patches, where they present as round, oval patches that resemble a ringworm. And so here is an example of a herald patch. And then later on, they present as a generalized rash with a Christmas tree appearance. And then the memory aid that I have for you is that Pete and Rose, so Pityriasis Rosea, sent me the Herald Angels Christmas cards. So the Christmas tree appearance of the lesions and the herald patches are characteristics of the Pityriasis Rosea. The next condition is Erythema Nodosum, which presents with red-violet subcutaneous nodules that develop in the pretibial location. So here is an example of Erythema Nodosum, where you can see that there are red-violet lesions in the pretibial location. And so this is a delayed hypersensitivity reaction to antigens. So example of which include like from infectious agents, from drugs, or other diseases like, for instance, tuberculosis or sarcoidosis can cause development of erythema nodosum. And then on histology, you will see inflammation of septa in the subcutaneous fat tissue. And then as for the treatment, you should treat the underlying cause, and upon the treatment of the underlying cause, the lesions will go away. The final condition is Acanthosis Nigricans, which presents as velvety hyperpigmented plaques that is usually seen over the skin folds, like for instance in the axilla or on the neck. And so this condition is seen most commonly with the insulin resistance, and then less frequently with internal malignancies. Now, conditions that can cause insulin resistance, for instance, include obesity, diabetes mellitus, as well as polycystic ovarian syndrome. And then once again, for the treatment of these skin lesions, you should treat the underlying cause, and then the lesion will be going away. And that concludes our discussion of different skin disorders.